Hello everyone, my name is Saber. I'm an anesthesiologist at Johns Hopkins University, and today I have the opportunity to give you a brief introduction into the world of anesthesia. Hopefully this can give you the big picture and potentially help you in your other rotations, or maybe even help you decide on anesthesia as a specialty. So I'll start with a common saying amongst anesthesiologists. If your favorite place in the world is the operating room, then be a surgeon. If your favorite place in the hospital is the operating room, then be an anesthesiologist. I think this speaks to the joys of working in the OR while being able to maintain a well-balanced life. Anesthesia, to me, is the perfect blend of science and medical management, where critical thinking comes together with action and procedural skills, and your decisions really have instant results, but also immediate consequences. But the challenges only add to the satisfaction and reward when a patient leaves your operating room better than when they arrived. And then to top it all off, most anesthesiologists have plenty of time to enjoy their life and pursue interests outside of medicine. So I'll start with a brief background on the history of anesthesia and how far we've come over the last century. And then after defining what anesthesia is, I'll dive into an example anesthesia case to cover perioperative goals and considerations. And this includes a review of some of the anesthesia pharmacology. Last, I'll briefly cover other important aspects of anesthesia, like regional anesthesia technique and the role of anesthesia in global health. So modern day anesthesia really didn't begin to develop until about 160 years ago. So from about 4000 BC until 1800s, anesthesia really just involved things like herbs, alcohol, and opiates. And so as you can imagine, surgery back then was very painful, bloody, and dirty. And it wasn't until 1946 when Boston dentist Dr. William Morton was responsible for the first public demonstration of ether. And at that time, anesthesia became heralded as one of the greatest gifts ever made to suffering humanity. So after many of what I'm sure were extremely disturbing experiences of patients becoming apneic, not breathing, and dying, we realized the need for safer airway management techniques. And so in the 1920s, the brass endotracheal tube was first developed. I'm sure that was very comfortable. And then in the 1940s, that's when muscle relaxation was introduced. But it wasn't until 1986 when safety and monitoring standards were finally established. And so this is what a typical operating room looks like now, where death rate has improved from 1 in 1,500 in the 1950s to 4 to 5 deaths per million anesthetic delivered by 1995. So what is general anesthesia? General anesthesia is a medically induced state of unconsciousness with loss of protective reflexes, resulting from the administration of one or more general anesthetic agents. The components of a general anesthetic usually involve some sort of hypnotic agent, something to induce unconsciousness, an analgesic for pain, and may or may not include muscle relaxation as well. And the combination is referred to as the triad of anesthesia. And the relative importance of each component depends on surgical and patient factors such as the type of surgery and the degree of pain or stimulation that's anticipated, and the technique is then tailored to each individual situation. So major surgery is associated with significant physiological stress and frequently adverse outcomes, and so it becomes very important to conduct a thorough preoperative assessment. First, to tie everything together, we'll start with a sample anesthesia case. So a 45-year-old 100-kilogram male with a past medical history of alcohol abuse, COPD, and poorly controlled hypertension presented with an acute abdomen and was found to have a perforated appendix. He is posted for an emergency XLAP and appendectomy. His vitals are a heart rate of 124, blood pressure 90/60, and respiratory rate of 24. So just pause for a moment and think about these questions. What are some immediate concerns regarding the patient's history, and how would this affect your anesthetic plan? So when it comes to goals of preoperative evaluation, they include things like assessing the patient's medical status and ability to tolerate anesthesia. And this involves reviewing medical records, medication lists, ordering any tests or consults that may change management, interviewing the patient to get more details on their medical history, and conducting a focused physical exam. So unlike the standard H&P, which you're used to, ours is much more focused with specific attention paid to the airway and to organ systems at risk for anesthetic complications. For example, undisclosed alcohol and drug use could lead to undermedication and awareness in the operating room. A person who has severe coronary artery disease may be at risk for a heart attack or a stroke, when all the medications we give in the operating room will drop your blood pressure. But one of the most meaningful roles of my job that occurs in the pre-op assessment is really just gaining the patient's trust and relieving any anxiety they have by providing psychological support or even relaxing medications if needed. So you have to understand this patient is about to go through what is arguably the scariest moment of their life. And as an anesthesiologist, you have the opportunity to really help guide them through this experience. And then finally, we prepare the patient for the procedure by describing the plan and explaining the risks associated with it. So the ASA classification system is one of the most widely used systems in medicine to help stratify the patient's health about to undergo surgery. So starting with an ASA of 1, we have a normal patient, and then moving to ASA 5, this is the patient that will likely die without surgery, such as a ruptured AAA. Our patient would normally be classified as an ASA 3, given he has COPD and uncontrolled hypertension. But since he has a ruptured appendix, this could easily be an ASA class 5E. And so this classification system alone doesn't predict perioperative risks, but when you use it in conjunction with a lot of other factors, such as the type of surgery, the frailty, and the level of conditioning, it can be helpful in predicting perioperative risks. And another method of classification that's also reliable as a predictor is functional status. And this is expressed in terms of metabolic equivalents, or METs, and typically a MET less than 5 is associated with more risk. And an easy way to stratify this is just ask, can you climb up a flight of stairs without difficulty? So anesthesia is innately risky, and one of the riskiest things we do is paralyze a patient, take away their airway reflexes, and have to intubate them and manage their airway. And so one of the most important aspects of any evaluation is assessing their airway. And so this involves a close inspection of their mouth opening and visualization of the soft tissues of the pharynx. And the Mallampati classification is one test that examines the size of the tongue in relation to the oral cavity. And so a Mallampati class 1 is where you can see everything, including the uvula and the tonsillar pilars on the side and the soft palate, whereas a Mallampati 4 is where you can only see the hard palate. So a Mallampati 3 or 4 is associated with difficult intubation, and other things are like a small mouth opening, decreased jaw movement, a short or thick neck, and most importantly, any history of difficult intubation. Fasting guidelines were put into place to help reduce the risk of pulmonary aspiration. So you can see here that for all elective surgeries, patients must not have any sort of full meal 8 hours prior to their surgery, but they can have clear liquids up until 2 hours prior to their surgery. Emergency cases are always considered a full stomach, including emergency obstetric cases, and people including emergency obstetric cases. Malignant hyperthermia is a very dangerous disease, and it's an inherited mutation in the ryanodine receptor, leading to uncontrolled release of calcium from the sarcoplasmic reticulum. And this results in excessive skeletal muscle contraction and can show up as masseter spasm or rigidity. And the increased muscle metabolism can lead to things like tachycardia, elevated end-tidal CO2, and then late findings can include hyperkalemia, which eventually leads to rhabdomyolysis, kidney failure, and cardiac arrest. And the agents that trigger this are halogenated gases or volatile liquids such as iso, cevo, desflurane, along with halothane and succinylcholine. And so this is why asking about anesthesia-related history is so important. And so if someone were to have any sort of risk for malignant hyperthermia, then we would make sure to remove all the triggers from the operating room and flush our anesthesia machine for at least 30 minutes. So using all this information, we then tailor our anesthetic plan to ensure a safe and effective surgery for the patient. Moving on to monitors and equipment. So on the most basic level, the anesthesiologist uses the anesthesia machine to control the patient's ventilation and oxygen delivery and to administer inhalational anesthetics. The anesthesia machine receives medical gases from a gas supply, controls the flow, reduces the pressure of the desired gases to a safe level, and then vaporizes the volatile anesthetics into a final gas mixture. And then this is then delivered to a breathing circuit. You'll have your inspiratory and expiratory hose right here. And this breathing circuit is connected to the patient's airway. A mechanical ventilator right here attaches to the breathing circuit, but it can also be excluded with the switch called the APL valve if you want the patient to breathe spontaneously or if you want to manually bag them using the reservoir bag. And then you have a CO2 absorbent, which is usually soda lime, and this absorbs the CO2 so that you can rebreathe and recirculate the same air, allowing you to use lower gas flows and conserve anesthetic gas. So when it comes to basic anesthetic monitoring, clinical patient monitoring during any type of anesthesia must include regular assessment of circulation, oxygenation, ventilation, and temperature. And this can be achieved with a pulse oximeter, a blood pressure cuff, EKG, and capnography. And then additionally, if you think that there's going to be fluctuations in volume status or temperature, or if it's a lung case, then temperature must also be measured. And this is important because hypothermia can cause coagulopathy, so increased bleeding, and it can also increase your risk of surgical site infection. So just to give you a little background on how the pulse ox works. So you have a light source that's emitting multiple frequencies and a detector. And it emits light at wavelengths of 660. This is red and it detects deoxyhemoglobin, and then 920 nanometers, which is infrared, and detects hemoglobin. And so the pulse ox uses an algorithm, which is essentially a ratio of absorption at both pulsatile and non-pulsatile flow. So it cancels out the non-pulsatile flow to output a percentage, which is your functional oximetry, your SpO2. And this is important because the implications are that when you have low flow, such as in a cardiac arrest or impaired peripheral circulation, like peripheral vascular disease, then your pulse ox measurements will likely not be accurate. Additionally, if a patient has blue nail polish, or if you inject dyes like methylene blue, or if the patient has a hemoglobinemia like methemoglobin, where there's similar absorption at two waveforms, and so it's a 1-to-1 ratio, and the output is 85% oxygen saturation no matter what. Along with carboxyhemoglobin, where it looks the same as oxyhemoglobin, and so you have an oxygen saturation of 95%, when obviously the patient is not getting any perfusion at all. Capnography is a very useful tool, and so this uses infrared spectrography. And you can see here, it's constantly sampling the gas that the patient breathes out. And so when the patient breathes out, you get an increase in your CO2. And then when they breathe back in, the end-tidal CO2 drops back down. And it's very useful for detecting different pathology. For example, if you see an end-tidal CO2 tracing like that, it means you probably intubated the esophagus. Here you can see that the CO2 rises much more slowly than normal, meaning that there's some sort of obstruction, which could be something like a bronchospasm or a mucus plug. And then if you see something like this, so end-tidal CO2 monitoring is extremely useful and necessary during any code situation because it gives you an idea of whether you're doing adequate CPR. And so here you can see the cardiac output begin to go down and then back up with resuscitation. And this is because when there's no flow to the lungs, then you're not getting any CO2 to diffuse out through the alveoli in the lungs. And I just wanted to touch briefly on the importance of preoxygenation. So here you can see an oxyhemoglobin dissociation curve. So an SaO2, an oxygen saturation of about 90%, corresponds to PaO2 of about 60. And so you can see once your oxygen levels begin to drop past this, you get a very steep drop, and it'll drop quickly to dangerous levels. And an PaO2 of 60 is about the minimum oxygen to prevent ischemia in your tissues. And so one way to think about this is lungs are a tank of oxygen stores, and when you're breathing room air, it's 80% nitrogen and 20% oxygen. And so you only have about 450 milliliters of oxygen. And that's why we pre-oxygenate to denitrogenate, get that nitrogen out of the lungs. And so with at least 8 deep breaths or 3 minutes of normal breaths on 100% oxygen, you increase your oxygen stores from 450 to 3 liters. And this means that you can increase your safe apnea time from roughly 1 minute to 6 to 8 minutes. And so this means more time to intubate and more time to secure the airway in the case of a difficult intubation. So going back to our case, this patient's history is notable for obesity, alcohol abuse, and severe lung disease, and poorly controlled hypertension. My biggest concern is his obesity and lung disease right now, which can mean a difficult airway and faster time to desaturation. I would anticipate this and make sure to have difficult airway equipment readily available and optimize patient positioning. Given his acute abdomen and vitals, I'm concerned that he may be septic and may require significant volume and medications to maintain adequate perfusion, so I'll make sure to have multiple large bore IV access and an arterial line to facilitate frequent blood draws for labs and have beat-to-beat measurement of arterial blood pressure. As this is an emergency case, I would assume that the patient is unfasted. This means I would perform a rapid sequence induction to reduce risk of pulmonary aspiration. So now we'll move on to a couple quick quiz questions. So the first question is regarding monitors. Which of the following is true regarding pulse oximetry? A. Oximetry uses two wavelengths to measure absorption in oxyhemoglobin and deoxyhemoglobin during pulsatile flow only. B. Carboxyhemoglobin has the same absorption as deoxyhemoglobin and will therefore give you a falsely low pulse oximetry measurement. C. Blue nail polish can interfere with pulse oximetry readings. And D. Peripheral vascular disease does not affect the accuracy of pulse oximetry measurement. So take a second and you can just click pause and try and come up with the answer yourself. So the answer is C. Blue nail polish can interfere with pulse oximetry readings. So pulse oximetry, remember, uses two wavelengths, 660 for red deoxyhemoglobin, and 940 nanometers for infrared oxyhemoglobin. And it measures absorption of both oxy and deoxy at both pulsatile flow and non-pulsatile flow. At 660 nanometers, carboxyhemoglobin actually has the same absorption properties as oxyhemoglobin. And so a higher concentration of carboxyhemoglobin will give you a falsely elevated saturation. And then other factors that interfere with pulse oximetry include blue nail polish, black and purple, anemia, hypothermia, and anything that causes severe reduction in blood flow, such as patients with peripheral vascular disease. So second question. During a preoperative airway assessment for a tonsillectomy, the patient opens his mouth and the soft palate is visible, but the uvula is not. What would this patient's Mallampati classification be? So take a second to just come up with the answer, and then we'll go over the answer together. So the answer is A, a Mallampati classification 3. And as you can see here, when you can only see the soft palate but not the uvula, that's a 3. And not being able to see the soft palate and only the hard palate would be a 4. And remember, it's important to perform any airway exam prior to any anesthetic. And the Mallampati scale is one of the most frequently used measurement tools. Other signs include a small mouth opening, a small thyromental distance, and a large BMI. So moving on, an understanding of pharmacology and when to use certain drugs is key to the art of anesthesia. So remember, pharmacokinetics is the process by which a drug is absorbed, distributed, or eliminated by the body. It's what the body does to the drug, whereas pharmacodynamics is the effects of the drugs on the body. So the ideal anesthetic is something that's easy to administer, acts quickly, and has a limited duration, renders unconsciousness, amnesia, while maintaining hemodynamic stability, and optimizes surgical conditions. So because there's no one drug that can accomplish all of this, we use multiple drugs for something that's called a balanced anesthesia. So induction drugs are the drugs that are generally used to produce sleep before you add the gas to maintain anesthesia. Some of the most common IV induction drugs include Propofol, which is definitely the most common because it's fast onset and fast recovery. It acts by decreasing the rate of dissociation of GABA, an inhibitory neurotransmitter, from its receptor. and so it increases the effect of GABA. And all hypnotics will also affect major organ systems besides the CNS. And with the exception of ketamine, most IV induction agents will definitely produce a dose-dependent respiratory depression. Additionally, they'll produce hypotension and myocardial depression to varying degrees. And propofol is one of the drugs that can definitely cause significant hypotension, especially in a patient who's hypovolemic or in the elderly. You'll definitely want to adjust your induction doses. Etomidate, like propofol, is a hypnotic that acts on GABA receptors. But more than propofol, etomidate has a much more favorable hemodynamic profile. The only reason that we don't use this all the time is because it can also impair the patient's ability to form cortisol and generate an adequate stress response. And so because of this adrenal suppression, we would avoid it in patients who might be adrenally insufficient, such as an ICU patient. So ketamine possesses several unique properties compared to other IV induction agents, and it's one of my favorite drugs to use in the operating room. So first of all, ketamine is an NMDA antagonist, and an NMDA is an excitatory receptor, and it causes dissociative anesthesia. And this also provides significant analgesia, and it has very little effect on respiratory depression. So this is a drug that's great for a trauma patient because of its hemodynamic stability and its minimal effect on respiratory function. But the negative effects of ketamine include things like hallucinations and nightmares, and this can be reduced with pretreatment with benzodiazepines such as midazolam. So this is just a table outlining some of the things I talked about. So above is a photo of the papaver somniferum plant, and this is a parent plant of the modern day opium and poppy seed. Opioids act on mu receptors in the brain and the spinal cord to produce most of their analgesic effects. This is definitely one of the most used medications in anesthesia, and it's used to control pain, but also to blunt airway reflexes such as hypertension or laryngospasm when inserting the laryngoscope. They have a well-known side effect profile, which includes respiratory depression, bradycardia, and hypotension when it's used with other drugs such as propofol, and it can also cause itchiness. So the reason why it's important to understand the pharmacokinetics of opioids is because, for example, Dilaudid, which has a peak onset of about 10 to 15 minutes, oftentimes is administered by an intern who's starting their first day of work, and their patient is still complaining of pain after 5 minutes. If you don't wait that 10 to 15 minutes, then you'll just continue stacking doses before you even begin to see the effect, and the patient may easily become overdosed and apneic and stop breathing. Morphine is your prototypical opioid, and it's the oldest drug in the class. It has a very slow onset time, but provides a very long duration. And hydromorphine or Dilaudid is in between morphine and fentanyl, fentanyl being the fastest peak onset and the shortest duration of action. Methadone acts for a very long duration with a half-life of almost a day, and it also is an NMDA antagonist. So knowing this, you can use each of the opioids to fit your needs in different situations. So fentanyl is great for standard induction because it's short-acting. Hydromorphone is better towards the end of the case because it can provide more longer-lasting analgesia. And then methadone is great for chronic pain patients. And it's also important to note that morphine and hydromorphone have an active metabolite that's renally excreted, and so you want to be very careful in somebody who's renally insufficient. So moving on to neuromuscular blockers. The non-depolarizing muscle relaxants are all relatives of the early arrow poison curare. And this is from the Amazon area where the Amazonians used curare on the tips of their arrows to shoot monkeys and would cause paralysis. So paralytics, as I mentioned earlier, revolutionized anesthesia for its ability to cause muscle relaxation, optimize surgical conditions, and facilitate safe intubation. And so I'm sure many of you remember this whole diagram, the neuromuscular junction. So depolarizing muscle relaxants, which is succinylcholine, resembles acetylcholine and readily binds to the acetylcholine receptor on the other side of this synaptic cleft. And so Unlike acetylcholine, succinylcholine is not metabolized by acetylcholinesterase, and so it lasts longer, producing a longer duration of effect. And because it's constantly depolarizing the receptor, eventually it can't be depolarized again, and so it causes a paralysis for anywhere from 5 to 10 minutes. And then it's redistributed and metabolized by acetylcholinesterase. And because of the way that it works, succinylcholine can have other side effects, which include hyperkalemia, which is released during muscle contraction. You can get myalgias because of the fasciculations, and then it's also a trigger for malignant hyperthermia. So non-depolarizing muscle relaxants bind acetylcholine receptors but act as a competitive antagonist because it does not cause an action potential. And so while you can have spontaneous reversal of the block through diffusion and metabolism, this may take hours. So thankfully we have pharmacologic reversal agents. And this includes neostigmine, which is a cholinesterase inhibitor. And this inhibits acetylcholinesterase activity, which increases the amount of acetylcholine in the neuromuscular junction to overcome the effects of the non-depolarizing muscle block. And because acetylcholine acts at cholinergic receptors everywhere, you can get muscarinic side effects from giving neostigmine. So remember that mnemonic dumbbells, diarrhea, bronchospasm, bradycardia? Yeah, all bad things that you don't want. And so that's why we always pre-treat with glycopyrrolate, an anticholinergic. Otherwise, you may cause a bradycardic arrest. A newer reversal agent, sugammadex, it exerts its effect, is the first selective relaxant binding agent, and so it acts by actually just forming these tight complexes with the non-depolarizing agent, and then that's cleared by the kidneys. So now for question 3 regarding induction drugs. So a 60-year-old male was admitted for a liver resection for cholangiocarcinoma 5 days ago. His postoperative course was complicated, and he has been in the ICU. Today, he developed fevers and worsening abdominal pain. He is brought to the OR for an abdominal washout. Blood pressure is 90/45, the heart rate is 115. Which one of the following agents is the best choice for induction of anesthesia? Is it A, ketamine, B, etomidate, or C, propofol? So the answer is A, ketamine would be the best choice for an induction of anesthesia. Remember, ketamine is an NMDA antagonist and acts as a sympathomimetic. So it actually stimulates the sympathetic system, and if anything, tends to cause tachycardia and higher blood pressure in patients when used as an induction agent. The only thing to watch out for is if the patient is depleted in catecholamines from prolonged stress. Ketamine also causes direct myocardial depressant effects, and sometimes they can cause a drop in blood pressure. However, the other answers, propofol, we know, causes a significant drop in blood pressures and decreased SVR from vasodilation and myocardial depression. But etomidate is a medication that we'd want to try and avoid in a patient who's been in the ICU for a while because of its effects on causing adrenal suppression and evidence that shows that it actually increases mortality in ICU patients. So question 4. Which of the following IV anesthetic depresses upper airway reflexes the most? A, midazolam, B, ketamine, C, propofol, or D, dexmedetomidine? So you can take a second to think about that. So the answer is C, propofol. So propofol leads to more significant depression of upper airway reflexes than any of the other drugs. Upper airway flexes are minimally affected by ketamine, midazolam, and dexmedetomidine. So moving into intra-op considerations. For a normal healthy patient coming for an elective surgery, anesthesia is often compared to as flying a plane. So takeoff and landing are often the most challenging and rough parts of the ride. But even at cruising altitude, you always have to remain extremely vigilant for any potential problems. So the induction. The induction of anesthesia refers to the transition from an awake to anesthetized state. And so this process of induction is a time of a lot of physiological disruption with multi-system effects. So starting with airway management, at the core of what we do as anesthesiologists is airway management. Anesthesiologists are the undisputed airway experts. And also remember that at our essence, our job is to deliver oxygen to tissues in the face of surgical stress. And you can't deliver oxygen without moving air. And under anesthesia, the soft tissues of the airway relax and they can collapse. And so you can see here the tongue and epiglottis might fall back against the posterior wall of the pharynx. And so manual maneuvers and simple adjuncts such as a chin lift, jaw thrust, and oral airway can be used to help keep this passage open. An LMA is one option to maintain their airway, also called a supraglottic device. It sits above the vocal cords, and it's less invasive and does not require paralysis. But it also does not protect against aspiration, so if somebody is at risk, such as someone who's very obese or has very bad reflux, then you definitely would not use an LMA. Intubation is obviously one of the most essential and life-saving skills in anesthesia. So some indications for intubation include a longer case that may require paralysis, for surgical optimization during head and neck surgeries, and then for airway access or the ability to isolate a single lung during a thoracic case. Additionally, if you need airway protection, like in those cases I mentioned earlier, somebody who's extremely obese, an emergency or obstetric case, or an intra-abdominal case where there's risk of aspiration, then you would place an endotracheal tube. And this is showing the sniffing position. So successful intubation often depends on correct patient positioning, and that includes moderate head elevation and extension of the neck, like you're trying to sniff something in front of you. And this helps align the pharyngeal and laryngeal axis, lining up your view for intubation. And now technology has improved significantly, giving us more reliable methods of intubation for a difficult airway. So on the left, we have a video laryngoscope, and this has a steeper curve, allowing you to overcome a small mouth opening or difficult to reach glottic opening. And then on the right is a flexible fiber optic bronchoscope. And this you actually control kind of like a video game and can precisely navigate the tip of your bronchoscope through the trachea with the endotracheal tube attached to it. A rapid sequence induction I touched on earlier. So this is specifically adapted process that's used when intubation of the trachea is required to minimize risk of regurgitation and aspiration. And so such instances include if there's a bowel obstruction, or if the patient is an emergency case, or they have a strong history of reflux. And so preoxygenation is extremely important, and preoxygenation with a fast onset paralytic like succinylcholine usually obviates the need for bag mask ventilation before securing the airway. And this is all so that risk of gastric insufflation and regurgitation is reduced. So maintenance of anesthesia refers to keeping a patient unconscious, and this can be achieved through a variety of techniques like inhaled volatile agents or continuous infusions of IV agents. So here are some examples of common anesthetic agents we use in the OR. So you have desflurane, isoflurane, SIVO, and the effect of the inhalational agent really depends on alveolar concentration. So the gas goes from the machine to the breathing tube, and then FA is your concentration of gas in the alveoli. FI is the concentration of inspired gas that you're delivering. And then it diffuses through the alveoli into the blood, and then finally reaches the brain. And so at equilibrium, the partial pressure of gas in the alveoli is equal to the partial pressure in the blood, which is equal to the partial pressure in the brain. And the goal is to produce a partial pressure of gas in the alveolus that equilibrates with the CNS and causes anesthesia. And this is a table outlining some of the values for MAC and blood gas coefficient. So MAC is the alveolar concentration that prevents movement in 50% of the population to surgical stimulus, and it's referred to as 1 MAC. And so the greater the MAC, or the greater the concentration needed, meaning the less potent that gas is. So you can see nitrous is has a very low potency versus isoflurane, which is much more potent. In fact, nitrous has such little potency. So if 100% nitrous is required to cause 1 MAC, which is prevention of movement in 50% of the population, That means that it's impossible to use nitrous as the sole anesthetic agent because this would require 0% oxygen. Blood gas coefficient, partition coefficient, is a measure of solubility of gas in blood. And so it's helpful to think of blood as kind of a reservoir or a tank that stores gas. And until this tank is filled, gas will continue to get pulled out of the alveoli, lowering your FA or alveolar concentration and increasing the time needed to reach equilibrium. And this in turn results in a slower induction and a slower recovery. And so you can see here, nitrous has a very low solubility, and because of this, the blood, or the reservoir, or the tank, gets filled very quickly. And so nitrous will reach equilibrium very quickly, and thus has a much faster induction and recovery, along with you're able to adjust the anesthetic depth when you change your concentrations, and it changes much more quickly. And then other factors that impact speed of induction and recovery include cardiac output. And so the faster that the blood is flowing past the lungs, the faster it's going to clear out that gas from the alveoli, slowing down induction. And you can see here that nitrous, with its very low solubility, has the fastest rise in its concentration, alveolar concentration. So all inhalational agents or volatile liquids decrease your cerebral metabolic rate and increase your cerebral blood flow. They also cause a dose-related decrease in blood pressure, some muscle relaxation, and dose-dependent depression of your ventilatory response to hypercarbia or hypoxia. Some things to note is sevoflurane is great as a bronchodilator. And then nitrous oxide tends to be more hemodynamically stable, but it also can diffuse into air-filled cavities. And so if you're doing an intra-abdominal surgery or intracranial surgery, you usually want to avoid this, as it can potentially cause problems like small bowel dilation, or if there's a pneumothorax, it could make that pneumothorax much worse very quickly. Emergence is the process of turning off all your anesthetics and allowing the patient to gradually regain consciousness. And so this is the recovery phase where reflexes gradually return. And just like induction, when a patient is emerging, there's a lot of uncertainty with the potential for complications. Additionally, we typically administer prophylactics like anti-nausea medications and pain medications, and then decide whether to extubate depending on certain criteria, but also clinical context. And then throughout it all, we continue to monitor the patient very closely until their physiology returns back to baseline and the patient is able to follow commands. So going back to our case now, with our newfound understanding of anesthesia pharmacology and intraoperative concerns, pause for a second and try to describe your intraoperative anesthetic plan for this patient. So what medications would you use for induction? What would your airway plan be for a safe intubation? After induction, how would you maintain anesthesia, and what adjunct medications would you administer to prevent common postoperative complications? So, given the emergent nature of this surgery and unfastest state with a possible difficult airway, I would first position the patient appropriately with a ramp and use a video laryngoscope for intubation. Additionally, I would plan for an RSI using succinylcholine, ketamine, and etomidate, all to optimize intubating conditions while maintaining as stable hemodynamics in the setting of possible septic shock. Opioids decrease sympathetic output, which may cause significant hypotension in its current state, but ketamine will still provide analgesia and allow me to use a smaller dose of etomidate. After securing the airway, I would ensure adequate vascular access with 2 large bore IVs and place an arterial line, and then I would maintain anesthesia using a volatile gas like isoflurane or sevoflurane and provide fentanyl as needed for analgesia. Since there will be an open abdomen, I would avoid nitrous, which may cause bowel distension, and then towards the end of the case, I would titrate in hydromorphone to respiratory rate, and as the hemodynamics tolerate, to provide a more longer lasting analgesia and administer antiemetics. Given his history of COPD, I would assess the patient's pulmonary function throughout the case and then his ability to be extubated. All of this being said, remember that in anesthesia, there's always a million ways to accomplish the same goals, and there's never one right way. And what's important is having a thorough understanding of the physiology and pharmacology and being able to apply that understanding to your plan. So, a couple more questions. Question 5. A 40-year-old female with a past medical history of obesity, type 2 diabetes, and hypertension presents with a complete small bowel obstruction. She is scheduled for a laparoscopic lysis of adhesions, and airway exam is relevant for a Mallampati 2 with a good mouth opening. She has no prior anesthesia-related complications. Which of the following is the best strategy to manage her airway? A. A laryngeal mask insertion. B. Bag mask ventilation with endotracheal intubation. C. Rapid sequence intubation. So you can pause and think about this for a second. So the answer is C, rapid sequence intubation. Remember, a rapid sequence intubation, or an RSI, is the airway management of choice for surgical patients when there is any sort of increased risk of aspiration. And this includes patients who are full stomach, like emergency patients, any kind of GI pathology, small bowel obstruction, gastroparesis, and remember, even diabetes can cause gastroparesis, and that's something to always think about. So question 6. At 1 minimum alveolar concentration, or MAC, what percentage of patients will move with surgical incision? So the answer is B. So we've talked a lot about general anesthesia, and now we'll move on to some other special topics and areas of importance in anesthesia. So while the anesthesiologist skill set will always include expertise in things like airway management and resuscitation, nowadays anesthesia has expanded significantly in scope and practice and includes a lot of responsibilities outside of the operating room as well. So we're experts in acute and chronic pain management, from managing postoperative pain to managing cancer pain and other chronic pain. We also provide labor analgesia and anesthesia for C-sections, and many surgical ICUs are actually run by anesthesiologists. In the upper right corner here, you can see some of my co-residents working in the COVID ICU. Our knowledge of critical care medicine makes us uniquely capable of managing really sick patients. Along with that, we're leaders in patient safety and quality improvement, especially when it comes to perioperative outcomes in the ICU. For example, the checklist to prevent catheter-related bloodstream infections, or CLABSI, in ICU, that saves thousands of lives and is used around the world, was created by an anesthesiology intensivist at Johns Hopkins. And then last, the reason that actually drew me to anesthesia was its important role in global health and improving access to life-saving surgery. And so in the bottom right, you can see a picture of me leading a simulation training program for nurse anesthetists in Sierra Leone. So to talk about some neuraxial anesthesia and regional anesthesia. So neuraxial anesthesia, spinal ARP and epidural. It can be the sole anesthetic, depending on the site of the surgery, which is anything abdominal or below. Or it can be used for postoperative pain control. And it can also be used during a case with general anesthesia to minimize the use of opioids. So epidural techniques are widely used for surgical anesthesia, obstetric anesthesia, and pain control, along with chronic pain management. Some advantages to neuraxial anesthesia include a decreased stress response to surgery, superior pain control to opioids, and minimizing all the negative effects that come with opioids, such as nausea, itching, decreased bowel motility, and most importantly, addiction. And all of this which results in increased length of stay. So some major contraindications to neuraxial anesthesia include patient refusal, coagulopathy. If somebody is severely hypovolemic, then having the sympathectomy would cause a further decrease and drop in your blood pressure. And also infection at the site of injection. So regional anesthesia is where you introduce a local anesthetic to a specific location surrounding a nerve to temporarily interrupt sensation or motor function to that specific part of the body that's innervated by that nerve. And technology has evolved significantly from the time when we used to just stick patients with a needle, and when they're screaming turned into a feeling of numbness in the desired location. That's when you're in the right spot. To what you can see here, which is a peripheral nerve stimulator. And so this is when we used to actually stimulate where our needle was, and if the correct muscle group was flexing, then that's when you knew you were in the right spot. But now, with the introduction of ultrasound guidance, we can actually place needles and local anesthetic with complete precision. And so remember your brachial plexus? Well, this is where it comes in handy to know it pretty well. So the majority of your upper extremity, as you know, is innervated by the brachial plexus. And depending on the location along the brachial plexus and where you block it, determines where you can achieve surgical anesthesia. So this is right here. These 4 different locations along the brachial plexus are 4 different blocks we can do for the upper extremity. This is one example of a common peripheral nerve block called the interscalene nerve block. An interscalene brachial plexus block is indicated for procedures involving the shoulder and the upper arm. And then this is an ultrasound image of the brachial plexus in the interscalene groove. So this is what we see as we're inserting the needle. And you can see the anterior and middle scalene muscles with the brachial plexus nerve group right here. So just to touch on something that's really important to me, the global anesthesia workforce crisis. And so to give you some background information, about 5 billion people lack access to safe, affordable surgical and anesthesia care. Many people aren't aware of the global anesthesia crisis in low-income countries around the world, but some countries have less than 1 physician per 10,000 people, and some, as you can see, many parts of Africa, have even less than 1 anesthesiologist per 100,000 people. And so, because of this, the ability to provide safe anesthesia for surgery, labor, and delivery, and other procedures, as well as for acute and chronic pain, is nearly absent in many of these countries, and this leads to a lot of unnecessary deaths and disability. So a large part of the disparity is due to a shortage of trained workforce, and for example, Liberia has 0 anesthesia physicians and 60 nurse anesthetists, and Sierra Leone has 2 anesthesia physicians nationally. So anesthesiologists are needed everywhere, not just to build capacity, but to help during times of crisis or disaster like the earthquakes in Haiti. And so to put it all together, not only is anesthesia extremely intellectually stimulating and challenging and fun and very hands-on, but it's something that's very needed around the world. And if you're passionate about working with underserved countries and people, then anesthesia really gives you an opportunity to do a lot of good work and make a difference. Well, this concludes my talk for today. Thank you again for this opportunity. I hope this was helpful. So stay safe and good luck on your medical journey.